Hello everyone, this is a video of laparoscopic segmental colectomy CME CVL for a case of distal transverse colon cancer. An 80-year-old lady with Alzheimer's disease, hypertension, BMI of 22, presents with anemia, altered bowel habit for 3 months. On evaluation, it found to have distal transverse colonic growth, biopsy revealed moderately differentiated adenocarcinoma with CA 4.2. So my plan is to go inside and first of all assess this is the growth. So there is no serosal invasion, no obvious enlarged lymph node both radiologically and on examination. There is no local infiltration, so no ascites, no evidence of metastasis. So my plan is to go ahead with, and the lesion was very close to splenic flexure, distal transverse colon. So my plan is to go ahead and do a segmental colectomy with central mesocolic excision, complete mesocolic excision with central vascular ligation. So after retracting the transverse colon, the inferior mesenteric vein, the fold of inferior mesenteric vein near ligament of Treats is identified and is reflected, and just below the inferior mesenteric vein there is peritoneal incision was given. So to enter into a plane, enter into the CME plane where it lies between the mesocolon and the zerotas fascia. So that plane we have to identify first. So once we identify the plane, the clear plane has been created between that, and following the embryological plane of dissection, without breaching the mesocolon, we can clearly do a complete mesocolic excision following that plane. Now I can see gradually I am pushing the, following the Tolles plane, I am pushing the gyrotous fat down and lifting off the mesocolon gradually. This is the left mesocolon. So gradually the left mesocolon is lifted off, and there was, during the process of dissection near the IMB, maybe there was a branch of artery of Moskowitz, so there is a bleeding, small sputter was there, so I clipped it, and initially one clip was applied, but there was bleeding, so I applied one more clip and the bleeding was controlled. So it was some arterial bits, some arterial branches was there, maybe some branches of artery of Moskowitz. So I have dissected it and I ligated it and sucked out the blood that has spilled, because during this process, this early phase of dissection, if the field gets blurred with blood, then it will be very difficult to identify the plane. So it is important to have a clear vision of the area of dissection, particularly in this pocket retrocolic window. So following this window and the same plane, we proceeded forwards from medial to lateral dissection, which usually we do in laparoscopic complete mesocolic excision. So medial to lateral dissection is continued till we reach the till we get a vision of the left colon, or reach the left lateral abdominal wall, following the same plane without entering into the gyrotous fat. So this maintaining this plane is very important. You can see a clear intact mesocolon is lifted off and there was no breach. So that is how a complete mesocolic excision should be done. And then following the same plane, dividing the white line of told, we gradually going up till the point where we have completed the dissection, and then we can see the wall of the colon, wall of the left colon. So that means we have the medial to lateral dissection has been done. So this is one important part of splenic flexion mobilization, because this CME dissection will help in mobilizing the left colon just distal to the splenic flexure, and gradually this, after this medial to lateral dissection, then above the inferior mesenteric vein, I am giving peritoneal incision and trying to identify the plane between the pancreas, anterior surface of the pancreas and the mesocolon. So this is the IMB, you can see. So gradually I'll be dissecting the IMB all around, and then we'll be ligating and dividing it. But before that, I'm just seeing whether other branches, that is the artery of Moskowitz, which is very close in relation with the close in relation with the inferior mesenteric vein. So this is a plane I am trying to identify, but before that I have decided to dissect the inferior mesenteric vein all around, and then we'll ligate it with harmonic shear. We'll divide the perivenous fibrofatty tissue. So inferior mesenteric vein will be ligated near the root, just distal to the root, 1 to 2 centimeter distal to the root. It is being ligated with hemlock clips, 2 hemlock clips, proximal and distal, and 1 liga clip towards the proximal here. Now we can divide the vein in between. So once we divide the vein, we can proceed further with the dissection. Now we can lift up the mesocolon from the anterior surface of the pancreas. This is the pancreas. So just where I am dividing now, just below it, this is the anterior surface of the pancreas, and I am just gradually lifting, clearing, creating a plane between the mesocolon and the anterior surface of the pancreas, and gradually we'll proceed further with the medial to lateral dissection. So you can see there is a clear plane, clear loose irregular tissue plane, and a good amount of traction with left hand instrument is very important, so that you can identify the plane in between, and there is a complete bloodless plane. So sometimes there are some branches, perforator branches are there, but in this case there was no other vessel in that plane. So I have proceeded forward with harmonic dissection, and you can see lower border of the pancreas and the body of the pancreas can be clearly seen, and gradually I am proceeding towards the tail of the pancreas. And now I have at the superior part of the pancreas, I have divided the fold and entered into the lesser sac. So there is a bulky mesocolon, bulky left mesocolon that you can see, which is being gradually lifted off very gently with good amount of traction and counter traction, with and good camera assistance is required to visualize this area and because sometimes you may tend to lose the plane. So after dissection of the completion of the medial to lateral dissection, I have kept a gauge piece at the lower border of the pancreas in between the mesocolon and gyrotous fat, and then took one more gauge piece where I have kept it into the through the window or into the mesocolon, through the window in the mesocolon into the lesser sac. And now I will come from the supracolic dissection. So supracolic and lateral dissection. So first of all, laterally the left colon is being mobilized now. So now you can see, using harmonic shears, I am pulling the left colon with my left hand, and then the plane that I have created from medial to lateral dissection, I will dissect up till that plane. I should connect both the planes. So you can see that is the lateral to medial mobilization now of the colon, and now the gauge piece that I have kept in the below the left mesocolon can be seen. So that two planes are being connected gradually now, so that I can completely reflect the left proximal part of the left colon from medial to lateral aspect, from lateral to medial aspect. So you can see I am going gradually towards the splenic flexure, and that is a lower wall of the spleen that can be visualized, and there is splenocolic attachments were divided using harmonic shears. So the left colon is completely mobilized now, gradually getting mobilized after dividing the lateral attachments of the left colon, because medial to lateral dissection was already done. So just to connect the dividing the lateral attachments, and then the complete left colonic mobilization is done till the sigmoid colon is being started. Till the starting point of the sigmoid colon, it is being mobilized nicely, so that once it is completely mobilized, we can do a tension free anastomosis. So little bit of dissection from the lateral aspect towards the lower pole of the spleen, and now coming to the dissection of the transverse colon. So this is the distal transverse colon. So one hand is pulling the greater omentum and one hand is pulling the colon, and I'm using harmonic shears. I'm staying very close to the colon and dividing the greater omentum, so that I can gradually enter into the lesser sac from there. So this part of the dissection is very important, because sometimes the bulky greater omentum you may tend to lose the plane, and then it is very difficult to identify and get into the correct plane. So staying close to the transverse colon is the key, and divide the greater omentum and reflect it away from the colon, and gradually you will be entering into the lesser sac. So I have already kept one gauge piece in the lesser sac through the window that I have created from the superior border of the pancreas. So once I see that gauge piece, I'll be sure that I have entered into the correct plane. So in this way I am mobilizing the distal transverse colon and going gradually towards the splenic flexion. So now you can see the glimpse of that gauge piece can be seen. So now I'm sure that I have entered into the correct plane. So that is the gauge piece that I have kept into the lesser sac. That is the plane of dissection. So that remaining part of the mobilization can be easily done now. The only part left is that a few attachments of the splenic flexure with the greater omentum, and using harmonic shear I am dividing it, and once it is being divided, the complete mobilization of the splenic flexure is done. So this is the most important part of this operation, probably left hem colectomy or segmental colectomy, where you need to mobilize the splenic flexure. If you follow the correct oncological principles and follow the proper anatomical planes, you will be able to mobilize the complete splenic flexure. Now further dissection towards the mid transverse colon is being done. So greater omentum is being divided, and the gradually from the tumor margin at least 5 centimeter proximal dissection is done. So from the tumor margin I have mobilized the greater omentum, divided the greater omentum 5 centimeter proximal. So my idea is to get a 5 centimeter proximal and 5 centimeter distal margin, along with complete mesocolic excision and central vascular ligation. So here in this case, as this is a distal transverse colonic growth close to the splenic flexure, I will be dividing the left branch of middle colic artery and the left colic vein at the root. So further mobilization is being done at the root of the mesocolon. So you can see the posterior surface of the stomach. So root of the mesocolon is being mobilized gradually, and on further mobilization coming towards the midline. So here I am getting the left colic vein. So this is the left colic vein near the root. So I am just dissecting it using harmonic shears, the all around and the right angle forces. So I have dissected the left middle colic vein 360-degree, and then with proper traction and counter traction I have ligated with hemolock near the root of the left branch of middle colic vein. Again hemolock proximal 2 and distal 1, and then the left branch of middle colic vein, and then after complete mobilization is being done, then the small 6 centimeter midline in upper midline incision given, the specimen was delivered. You can see the growth. So it is being delivered out, and we have adequate mobilization and adequate margin. So I have the 5 centimeter distal and 5 centimeter proximal margin after ligating the left branch of middle colic vein, and then side to side isoperistaltic anastomosis, stapled anastomosis was done, and the enterotomy was sutured, and a drain was placed. So colocoelic anastomosis with the transverse colon and the descending colon anastomosis was done, and the drain was kept. And this is the final specimen. You can see the complete mesocolic excision with central vascular ligation was done. So biopsy report was T3N0 with adequate lymph nodes were retrieved. This is the port positions, and patient recovered well and discharged within post-op day 4. So in early distal transverse colon cancer, laparoscopic segmental colectomy with CME CVL can be oncologically safe with similar long-term survival and disease-free survival with better functional outcome compared to laparoscopic left hemicolectomy. Thank you.